So today we're going to talk about tuberculosis and HIV in rural South Africa. The work that I've done there with the Yale AIDS program with Jerry Friedland, with people who are sitting in this room, has been a wonderful endeavor thus far, and I'm happy to be here to talk more about it. So the title of the talk is addressing TB in a high prevalence setting in rural South Africa, to focus on the 3 I's. I'm not sure how many of you know what the 3 I's are, but you will by the end of this talk. This is just an outline of what we're going to be talking about today. I'll do a little bit of background about TB. This is not something that we talk a lot about here in the US. We'll talk about the setting, what the 3 I's are, and then in more detail the actual work that's being done. So just a little bit about tuberculosis. Mycobacterium tuberculosis is a bacteria, mycobacteria, that is ubiquitous globally, and transmission occurs through the airborne route. Certainly coughing is something that we all recognize. Sneezing and talking as well can generate aerosolized particles from our respiratory tracts and get it up into the air, where it can then be inhaled by someone else. And this picture that you can see here is demonstrating that. It is inhibited by UV light, and as such, we generally think of transmission occurring in areas where there's little ventilation, little airflow, and where there's little exposure or less exposure to sunlight. HIV patients with a compromised immune system are particularly vulnerable to HIV infection and to progression more rapidly to active disease. So that's also something that's the crux of what we're going to be talking about today. Because of the diminished immune response that HIV patients have, they are a vulnerable population. It certainly co-infection complicates diagnosis and management of the disease. And unfortunately, because of these issues, TB is a leading cause of death for HIV patients around the world. Just some general information. Nearly 9 million cases of tuberculosis globally in 2010, almost 1.5 million deaths from TB in 2010. And a significant proportion of those deaths disproportionately occur in HIV-infected patients. The thing that I'll emphasize here is that TB is a treatable disease. We have perfectly good therapies, antibacterial, antimycobacterial therapies to treat people with TB. But unfortunately, for a variety of reasons, HIV patients suffer tremendously from this disease and have experienced increased mortality. Just for reference, I'm putting up some information about here in the US. So you can see that we are down at historic lows here in the US as of 2010, last available data that we have from the US CDC. We used to get, in the 20 to 30,000 range cases per year across the US. You see a surge here in the early 90s. Does anybody know what that might be attributable to?
Rise of HIV.
Exactly, the rise of the HIV epidemic here in the US. But with a lot of investment in the US public health infrastructure, we were able to bring that, get that under control and get this down year by year. Again, we're down at historic lows. And these are just the numbers for reference. In 2010, we've had about 11,100 cases in the US, and the rate is 3.6 per 100,000 in the US, and that'll be an important number to remember later on. So again, as a reminder, 9 million cases compared to our 11,000 and change here in the US. 9 million cases around the world. Approximately 13% HIV co-infection. The vast majority of that burden is in sub-Saharan Africa. 1.5 million deaths, about a quarter of those occurring in HIV-affected patients. So there's a disproportionate response there. Unfortunately, among TB patients internationally, we don't know everyone's HIV status. We know that the diseases are inextricably linked, but for a variety of reasons, to do in different healthcare systems, the TB people are over here, the HIV people are over here. They're very vertical silos in various healthcare systems, and they don't often talk to each other, even though the patients are one and the same. So for many years, up until just in the last couple of years, among TB patients, the HIV testing wasn't being done and being documented accordingly. So we only know people's status in about less than a quarter of all 9 million cases. And then another thing that we'll touch on today is the fact that there's more than 400,000 cases of MDR-TB internationally, and that number is growing. And we'll talk a little bit more about what MDR-TB means in 1 minute. 34 million people living with HIV internationally. Again, the vast majority of that is in sub-Saharan Africa. 2 million deaths a year, and very small proportion of people who need and are eligible for antiretroviral therapy are getting it. And this is all background for what we're going to be talking about today. So you can see and these are WHO figures. In 2010, the estimated TB incidence around the world. The lighter color green is lower incidence rates, and the higher or darker color greens indicate higher incidence rates. So again, you can see that we are in the lowest risk, lowest category, and that's 0 to 24 cases per 100,000. And then you can see in the darkest color, that's more than 300 per 100,000. You can see the darkest color being here in the world. Again, the vast majority of the burden is in this part of the world. And similarly, same thing, the lighter color indicates a lower incidence, and higher color, or darker color indicates a higher rate, higher HIV prevalence. And HIV prevalence in new TB cases is greatest, in this part of the world. Just to illustrate what we were talking about. Okay, some basic terminology. So when we talk about MDR-TB, or multiple drug-resistant TB, this means that we're talking about organisms, mycobacterial organisms, that have resistance to 2 of the first-line TB drugs, and that's isoniazid and rifampin. So that's very important to know. As a result, it becomes much more difficult to treat, and the remaining other options for therapeutics that we have are less efficacious, have more toxicities, and the therapy treatment courses are currently much longer. And there's a much higher mortality rate associated with MDR-TB. XDR-TB, defined as an additional layer of resistance, so MDR-TB plus resistance to a quinolone and an injectable agent, one of the 3, amikacin, kanamycin, or capreomycin. So for you guys to understand those terms, and I'll just mention that this work defining or detecting XDR-TB, or extensively drug-resistant TB, was from 2005 to 2006, reported in the Lancet in 2007 by Jerry Friedland, who just walked in, who I've had the fortune to work with the last few years. There was 53 patients with XDR-TB identified in Tagalog Ferry with a very high rate of mortality, 98%, within a very short period of time. So since then, MDR and XDR-TB have been reported throughout South Africa, throughout the world, and there has been a lot more attention paid to tuberculosis. And again, just to highlight, MDR, and the same color scheme goes, the darker the color, the higher the rate. The most in the world has been, the burden of MDR-TB has been here. And XDR-TB, you can see, has been detected all over the world, including here in the US and in the rest of North America. So that's not, drug-resistant TB is not limited to another part of the world. It's a very real issue for all of us. So a little bit about South Africa. A population of approximately 50 million, and the incidence of TB is nearly 1,000 per 100,000. Who remembers what the incidence in the US is? That number I told you to remember before. I'm hearing it, I think. 3.6 per 100,000, absolutely. So just for frame of reference, you're talking about order of magnitude difference here. South Africa leads the world in some of these health indicators. These are unfortunately not positive indicators, but 5th in the world in terms of TB cases, 4th in the world in terms of the amount of drug-resistant TB cases, and has the honor of being the #1 country in the world with the largest burden of co-infection HIV and TB cases, more than 1/3 of the cases globally. In South Africa, the estimated mortality from TB is 50%. Remember when I said TB is a treatable disease, and yet in parts of the world, more than half the people who get it are dying from that disease. And these are just some photographs of the area that we work in. It's a very traditional style home, traditional Zulu home from the eastern part of South Africa where we work. Similarly, a traditional Zulu home, traditional dress. You can see that this is the status of most of our roads. This is probably a better one than most. Very dry, arid, not great for vegetation, though quite beautiful. So, like we talked about what was happening in the US, you can see here that over the last couple of decades, as the TB rates were rather flat, and then once the HIV epidemic rose, you could see a concurrent increase in TB cases. So in this part of the world, certainly HIV and TB are inextricably linked. Tugalaferi. So to orient you, the African continent, South Africa is at the southern tip. We're looking at the eastern side of the country. This area that's colored in is KwaZulu-Natal province, and the different colors represent different districts. This is Umzinyathi district, this brown color here, and Tugalaferi is kind of smack dab in the middle of Umzinyathi district and KwaZulu-Natal province. It's approximately 3 hours inland from Durban, which, if you're familiar with the area, is the largest city, and on the coast approximately here. So the Tugalaferi area here is approximately 180,000 traditional Zulu people with a very high HIV antenatal prevalence rate of at least 1 in 3 pregnant women are HIV positive. Again, the TB incidence in this area is almost 1,100 per 100,000, so higher than the rest of South Africa, and certainly much higher than in the US. This area is characterized by extreme poverty, very high unemployment, lack of electricity, and lack of access to clean water. We work in Tugalaferi where there is a district government hospital, 350 beds, that serves that whole catchment area, 180,000 people. So now moving on to the 3 I's. So the WHO, the World Health Organization, has promoted a 3-pronged approach for TB control, particularly addressing TB and HIV infected patients. And that is infection control, intensive case finding, and Isoniazid Preventive Therapy. And we'll talk about all of these individually. So to start off, we'll talk about infection control and exactly what that means. So TB infection control, we are concerned about transmission of tuberculosis from one person to another. So we're trying to stop the spread of tuberculosis between and amongst patients and between patients and healthcare workers. And again, to limit the spread, the spread of TB and MDR and XDR TB has been well described in the literature to healthcare workers, certainly, and to other patients. The XDR TB epidemic that was initially detected by Dr. Friedland's work, as I mentioned before, was noted to be likely driven by nosocomial transmission, meaning it was likely spread within the healthcare system. So all those patients, those 53 patients, more than half of them had been in the hospital recently. There was healthcare workers who also had the MDR and XDR TB. And when the genotyping, looking at the genetic elements of those particular mycobacteria, the vast majority had the same genotype. So all of which indicated that it's transmitted nosocomially. We've done studies as well to look at transmission outside of the hospital, and work that was done by a PhD student here out of the School of Public Health, Sanjay Basu, did a modeling study that estimated transmission of MDR and XDR TB into the community, and that would, without any sort of intervention or attention to TB in this area, that community transmission would predominate. So moving from a healthcare facility out into the community that would perpetuate the epidemic. And certainly looking at household contacts of MDR and XDR TB patients, approximately 3% were found to concurrently have active TB, and that study was from a couple of years ago and supports that. When we talk about TB infection control, there's three main components that we are concerned with, and that's administrative controls, so healthcare policies at an institution-specific level that would govern how patients move throughout the facility to limit their exposure. So for example, if you have someone who's coughing and you're concerned about them having TB, making sure that they're not spending a lot of time sitting in your waiting room around other patients, making sure they kind of streamline them to get attention by the nurse or doctors as quickly as possible. So putting policies like that into place. Personal protection, so making sure all your healthcare workers are wearing masks, respirators to protect themselves, making sure that patients who are coughing exhibit cough hygiene and perhaps wearing masks of their own to limit transmission amongst patients. And then environmental controls. And environmental controls can include several things. We're going to talk today about a project that we did, effective natural ventilation at the household level. Again, all of our work has been focused on moving away from healthcare facilities and moving into the community. So this is the first project we'll talk about. So we wanted to look at the effect of natural ventilation, improving airflow to diminish the risk of TB transmission. And that's been shown to be helpful in healthcare facilities, but is it a useful tool at the community level? So in this project, we went into the community, we looked at people's traditional Zulu homes and did multiple measurements to look at this issue. So there was structural measurements, ambient air measurements, including temperature, wind speed, airflow direction, and then ventilation measurements. And here, the way this was done, you can see it in the bottom right-hand corner. We had a big old CO2 tank. We were able to close up the entire room, released CO2 from that tank in the room, and looked at the concentration of CO2 in the room using a CO2 meter, and looked at the rate of decay in parts per million. And that is able to be translated into air changes per hour. Looking at it, then that's a calculation looking at the log of the CO2 concentration over time, and the best fit of the slope of the line is air changes per hour. And that's a common measurement that's used for ventilation studies. And then using that air changes per hour estimate and plugging that into the Wells-Riley equation, which is the best current model available for TB transmission, and that gives us an estimated TB risk. So you can see here that in the closed condition, i.e. with all the doors and windows closed, the air changes per hour were 2.4. Again, air changes per hour is the number of air changes. For example, in a room like this, if we closed off all the doors, turned off the fans and the AC, how much what would it take to, how many air changes, how many times could we turn over all the air in this room? Take out all the air, move it out, and replace it with all new air. How many times would we do that in 1 hour? So if everything is closed up, the air could turn over 2.5 times. If we open the windows a little bit, the air turns over 7.4 times. If open the windows all the way, 11.8, and if we open the doors and windows, 21 times. Where would you rather be sitting? Which room would you rather be sitting in? I'm guessing all of us would rather be here if we had the option. Where would we want to live? We would want to live where we could have this. Similarly, and correspondingly, translating this, again, this air changes per hour into proportion TB risk, or the estimate of TB transmission. If you are sitting in the closed condition with 2.5 air changes or air turnovers, your risk is nearly 60 of getting TB. And this is over a finite period of time, over 10 hours. And at the other extreme, if your ACH or air changes per hour is 21, you turn over the air 21 times in the room, your risk is much, much less. Not eliminated, but much, much less. Again, where would we all rather be? I think we would rather be someplace where the ventilation is very high and our risk is low. So this is what we were able to demonstrate in people's homes. And looking at what the most important factors were that would contribute to air changes per hour and improving ventilation in people's homes, we came up with 2 separate models. One a more technical model that we thought would be more helpful for people building homes, architects and engineers and such, which is window volume ratio, in addition to opening all the doors and windows, the ventilation. That was certainly a very predictive factor. Again, the bigger the windows, the bigger the volume, and that relationship would be helpful. The other model, which we thought was more a practical model and easier for our lay community members to understand, is the house shape and material. So we found that people who had round and thatched roofs, round huts with thatched roofs, did not breathe as well as box-shaped houses with metal roofs, and those are the 2 predominant styles of construction in our area. And then again, increasing the number of windows also helps. And that all makes intuitive sense. But this hasn't been looked at all at the community level. All the work has been done in healthcare facilities. So I felt that this was helpful information to be able to convey to people, so to understand the importance of ventilation. And again, you can see here, this top diamond line is closed condition, and this is estimated TB risk on the y-axis and time. So you can see the same remains true with increased exposure. As the ventilation improves from closed down to windows open, down to windows and doors open, you can see the estimated TB risk decreases over time. If you compare the risk at 2 hours in the closed condition, with everything doors and windows closed, the risk is approximately 20%. At 24 hours, the risk is the same if you have all the windows and doors open. Again, to emphasize the effect and the diminished risk with improved ventilation. So we know from this work that ventilation at baseline with all the doors and windows closed is generally poor and may facilitate transmission. The use of more and larger windows and doors, if you can open them and keep them open, would certainly diminish the risk. And this is information that we can pass along to the local Department of Health so that we can communicate the risk and ways to decrease the risk to community members. In terms of next steps is trying to implement this for community members, and also look at community members' knowledge of infection control. Do they understand ways that they can intercede on their own behalf? And what barriers there may be to implementing such a strategy. Okay, so now we're going to move over to the next I, intensive case finding. And what is intensive case finding? This means, this refers to strategies to improve the diagnosis at an earlier stage of disease of tuberculosis, to improve their outcomes and to decrease transmission. We're actively looking for TB cases. We're going out to the community, or going out and looking for people with tuberculosis instead of waiting for them passively to come into the healthcare system. I think there's questions around this strategy in terms of how do we diagnose tuberculosis when we're doing this active searching for cases? Are we looking for people with symptoms? Are we going to collect a sputum for evaluation on everybody? Are we going to do a chest x-ray on everybody? What groups are going to be at the highest risk? Which populations are we going to screen? Are we only going to focus on HIV patients? Or are we going to look at everybody in general in these endemic TB settings? Where are we going to screen them? Are we only going to focus on the healthcare facilities, or are we going to go outside of that facilities? And then again, who will perform the screening? You need dedicated staff to do this, but do they need to be clinical staff? Can we train high school students to go out and educate people and to look for people with symptoms, as an example? So the state of the field at this moment is that there's been a focus on case finding primarily in known HIV patient populations. Again, the highest risk group, as we described before. What we're doing currently is a novel community-based strategy. Again, we're going outside of the healthcare facility to community, where in these high prevalence TB endemic areas. We're working currently with the local Department of Health, and what we've launched is a TB screening effort, a TB case finding team that's integrating the TB and HIV components. So we have a team of nurses and HIV counselors and field health workers who go out to various congregate community sites, offer health education regarding TB and HIV, offer HIV testing. If someone is found to be HIV positive, we offer them a CD4 count, a blood draw for CD4 count. We screen them for TB symptoms. If they have symptoms, we collect a sputum for smear and culture. And then we're going to follow up their overall clinical outcomes to see, are they better off having been diagnosed earlier at the community level, as opposed to waiting for them to have come into the healthcare system on their own. And I've just listed here the various community sites that we go to. Again, we're trying to take advantage of community settings that are already occurring. So municipality events that the local government is having, and those happen on a fairly regular basis. Pension pay points. Those are the points where people come out to get their once a month social welfare grant. We have a big armored truck that comes driving out into the middle of nowhere and stops at a certain point on a certain day, and hundreds of people will show up on that particular day, but any other day there's nothing there. And they literally give out their people's monthly social check off the back of the truck. Taxi ranks, where there's a lot of people crossing paths, and a good site to attract a lot of people. We do go into prisons, and that's been at the invitation and partnership with the local Department of Corrections. We were going into secondary schools when we started. In February 2011, there became more concern in the country about the impact of HIV testing and diagnosis amongst young people, and the government put a stop to that for the time being. They're looking at ways to optimize that kind of testing in the future, and hopefully it will resume. But for the moment, there's a moratorium on that. And then certainly health fairs and other community events that are occurring in the area. Home-based care events, those are events organized by our local community health workers who work in people's local neighborhoods and organize events to care for their community. And they invite us in. So this is just some pictures of what this looks like. This is our mobile clinic, our nurses and healthcare field health workers at a taxi rank. It's a little bit hard to appreciate the taxi rank, but you have to believe me when I say that that's what that is. We have some people who, or some others who are also interested in our services here in the side of the picture. This is a home-based care event, so literally out in the people's communities in the neighborhood under a tree. And we would bring all of our equipment with us, chairs and tables, and set up where people are. One-on-one counseling and administration of a questionnaire. This is at a secondary school. You can see the school in the distance. And it attracted people other than just the students, but people who lived in the vicinity, people who worked at the school, et cetera. And then again, this is an illustration of the health education that's going on. This is one of our nurses handing out condoms. So from March 2010 till June 2012, we have now screened more than 5,400 people at the community level, over 320 visits to the community. The vast majority of people are willing to have their HIV test done under in this setting and under these circumstances. Vast majority of people are interested in getting an HIV test and willing to have that happen. 91%. 10% of the people that we're testing or people that we're screening in this kind of environment are HIV positive, are identified as HIV positive. We are, as I said, we offer, for those who are HIV positive, we offer phlebotomy for CD4 count. The vast majority is taking advantage of that, and the median CD4 count is 379. And when we deliver these results to them, we bring the blood back with us to the hospital, and then once we have a result, we go and find them again to deliver the results and counsel them with the appropriate next step. So currently, the criteria for starting antiretroviral therapy is 350. So if we find a CD4 count result of 475, we can go back to that patient and say, you need to recheck your CD4 count in the next 3 to 6 months, but currently you do not qualify for antiretroviral therapy. If we have a CD4 count of 180, we can go back to that patient and say, you qualify for antiretroviral therapy right now, you need to get to the clinic and start the process of getting onto the drugs. On the TB side, we've identified nearly 1,000 TB suspects, people with symptoms who are able to give us the sputum for microbiological examination. And the vast majority have their predominant symptom being cough greater than 2 weeks. You can see that 15 are Zeal-Nielsen or Oramine smear positive, so a very low proportion. 35, or 3.7 overall, have microbiologically confirmed TB, and that means smear or culture, and does not double count the smear or culture results. So there was 4 patients who we had an AFB positive without a supporting culture, 17 patients who had drug-susceptible TB, nearly half, and more than a quarter had drug-resistant TB that we were able to identify at the community level. All 10 of these patients were identified. Once we had the culture result, we were able to go back to them and then found them that they were still alive, and we were able to refer them into care. In contrast to the current or historical situation where by the time we identify patients, by they come into the healthcare system, we get a culture, and by the time we get the culture results, which take a month or 2 to come back at a minimum, we go back and find that half of the patients have already passed away because of that diagnostic delay. But in this case, we're able to find everybody and get them referred into the healthcare system. And then we did have a few where the drug susceptibility testing was contaminated or is still pending at this point. But we knew it's culture positive TB. And you can say that there's approximately a month that it takes before we're able to get a final culture and drug susceptibility testing result. Oh, there we go. So is this strategy and the people that we're finding or testing in this environment, are they representative of the general population, or are there some differences? we looked at approximately 153 patients in a subset that represented people who were participating in the ICF services and those who were not participating. And basically there was really no difference in terms of socioeconomic status or demographics, or in terms of previous HIV or TB testing or treatment. So that was that would indicate to us that this strategy is reaching a representative sample of the population, and that the figures and epidemiology that we're seeing here are representative. So among the 91% that did have a HIV test, the vast majority are women, and that's reflective of our local population. Most of the men end up going elsewhere to find work, and the vast majority, 3/4, will remain the adults are women. It's a somewhat slightly older age group than what we were expecting. When we think of targeting HIV services, we think of younger populations who are, in theory, more sexually active. But clearly, the people who are taking advantage of the service are slightly older than we would have thought. Almost half of the people were undergoing an HIV test for the first time. And that was a bit surprising to us. We thought that we were going into the community and targeting a population who did not or had poorer access to services. We actually thought that this would be a lot higher. So 50%, the other way to look at it is 50% have had a previous HIV test and are undergoing serial testing. So the public health education that's occurring about HIV in this area is seeming to be effective, and people are recognizing risk factors in their own lives and or seeking out, taking advantage of the service. Again, among the nearly 500 that were identified as HIV positive, of the people who were first-time testers, 12.5%, 13% were HIV positive. Of the people who had been tested previously, 7.7% were known to be positive previously. So again, people are retesting. Anecdotally, what we're hearing from people is that their previous testing experience was not a good testing experience. They had had some level of mistrust with the person providing the test or the environment in which it happened. Or what we're hearing is that people were diagnosed as positive previously. They sought out a cure from a traditional healer, and then they're coming and testing with us to confirm whether or not that cure worked. So again, this is anecdotal. We haven't evaluated that in a more systematic way, but it certainly is very interesting that a lot of people knew that they were positive are coming to us for repeat services. That was a surprise. Again, 42% of all of the patients that tested with us knew that they were positive already. And this is work that was done by a student who worked with us before. Again, a short-term questionnaire looking at people's motivations. Again, the vast majority are female, approximately 39 years was the mean. But in terms of why people were testing for HIV, 12.6% recognized that they had some sort of lifestyle issue that put them at risk for HIV infection. Very few people were testing because they were pregnant. We can only assume that people were being caught by the antenatal care services of the government. Others were being tested just because they were not feeling well. So again, this needs to be further evaluated. The people who said that they were feeling ill ultimately had lower CD4 counts. Again, people are recognizing the possibility of HIV infection in their lives. New HIV diagnoses were more likely to test than known HIV diagnoses due to concern for a risky lifestyle. And then in another survey that we had with a student, we had approximately 287 community members against screeners and non-screeners who were surveyed, and in terms of their knowledge of TB and HIV disease. And so suffice the blue is the TB, and the red is the HIV. And you can see on a score of 16 questions related to TB and HIV disease, separate questionnaires, the overall knowledge of TB was lower than that of HIV. I think what we take away from this is that the public health education has been wonderful about HIV, and there's been a lot of progress that's been made. But even though TB has been around a lot longer, there's less knowledge or less accurate knowledge about what is involved with TB transmission, the causes of disease, and potentially treatment. Okay, so coming back to our community work, it was important to us to utilize a variety of different community congregate settings to identify people. I think initially when we started out thinking about this work, we thought we would only focus on pension pay points, thinking we'd get a nice cross-section of people in the population. I think over time we learned, or very early on, we learned that that was going to be insufficient and that we needed to use a variety of different sites. So you can see that in terms of the number screened at each of these different types of sites, the number number in proportion positive by site. The most common place where we had HIV positive patients, the highest proportion were in prisons and taxi ranks, followed by health fairs and municipality events. Fortunately, very few HIV positive people in schools, but again, that was a very small number because of the moratorium that was put into place. What predicted HIV positivity in this community sample? So age, marital status, the fact that they had previously had an HIV test. So remember I said many people knew that they were already positive. Having contact with a TB patient in the last 12 months, whether they're on current TB treatment, the type of community site, which we talked about just in the last slide, and other clinical factors, whether they've had a lot of respiratory infections, they've had shingles or thrush. In terms of symptoms, there's a variety of different symptoms here that were associated with having a positive HIV status. On the TB side, again, the number of the different congregate sites, the number of people screened at each site, the number of TB suspects in terms of people who gave us a specimen at each site, the proportion at each site. Overall, we had approximately a quarter of all people we screened that had TB symptoms. And the number and proportion microbiologically confirmed at each site. So you can see that the rate, or 2.7%, was the highest in prisons, followed by taxi ranks and then health fairs and municipality events and home-based care. So quite a spectrum there. And then again, what predicts TB in this community sample? So gender, not having electricity, the type of community site that we just talked about. Interestingly, and I think something that we were very surprised about is that HIV status did not predict TB in this community sample. And we'll talk about that more in 1 minute. In terms of symptoms, cough, greater than 2 weeks or cough of any duration, night sweats and weight loss, chest pain, and shortness of breath. Those are things that intuitively do make sense to us. So looking at the overall summary of what this work has shown so far, I'll just focus on this column right here. In terms of microbiologically confirmed TB in this community sample, we're looking at a rate of 641 per 100,000. Meaning we would need to screen, NNS is the number needed to screen, that is a common measure in screening studies. We need to screen 156 people to find one patient with TB. And I've put down here the rate of smear positive or microbiologically confirmed rates from our local health department. So 24 to 29% of the TB that's captured by the healthcare facilities is smear positive. The rest are clinical diagnoses. and approximately 274 per 100,000 in the healthcare facilities. So what we're finding in the community sample is certainly the same or much higher than what we are seeing in the healthcare facilities in terms of microbiologically confirmed tuberculosis. One limitation of that is that this does include culture. These are just smear positive cases, but that's the local practice. It's the best we can compare to at this point. So again, in the province, approximately 70 to 80% of the TB is HIV co-infected. In our area, from the healthcare facilities, we know that approximately 64% of all the cases of TB that have been diagnosed in our healthcare facility at our hospital are HIV co-infected. But what we're seeing is approximately 8.5% HIV co-infection, which is significantly different from what we're seeing in the healthcare facilities. And again, that was a surprise to us. And our speculation is that what we're seeing at the community level is a large reservoir of TB in non-HIV infected patient populations. And what we're seeing come into the health facilities are the particularly vulnerable and susceptible people who get sick and become ill much more rapidly with active disease. With colleagues here at the Yale School of Public Health, Dr. Paul Thiel, Dr. Galvani, and Jennifer Gilbert, we've been able to start to model what the impact of this strategy would be. Looking at, for example, this, the lowest line here on the left is an ICF strategy that covers 15% of the population per year. You can see the number of TB cases that would be averted, almost 500 over the next 10 years. If you were to expand this to 90% of the population every year, and that's represented by the purple line here, over the next 10 years you had the possibility of averting 2,500 cases. Similarly, on the HIV side, with 90% of the population getting intensive case finding, 1,400 cases of HIV could be averted. So what's happening to these patients that we're identifying? And this is preliminary outcomes work at this point. Just on the HIV side, I'll point out that, again, of those 500 people who we've identified as HIV positive, 135% of them are eligible for antiretroviral therapy on the basis of their CD4 count of 350. Only 30% of those patients have initiated antiretroviral therapy as of yet. Among those who have initiated, their median CD4 count is 247, but it's still taking them quite a long time to get into care. So when we started this work, we thought that the biggest obstacle for people was knowing what their status was, i.e. getting an HIV test, and perhaps getting a CD4 count because of the lengthy delays in the healthcare system in terms of getting those tests done. But I think what we're finding is that this, despite the fact that we're going out to the patient, not waiting for them to come to the healthcare system, that there are still other obstacles that we need to evaluate and address before we can get everybody who needs to be in care into care. In terms of next steps here, we are in the process of analyzing the data to see if we can identify any differences predicting those patients who actually started antiretroviral therapy. So what does this all mean? That community-based intensive case finding is an effective strategy for early case detection for both TB and HIV, that using a variety of congregate settings is very important, that the epidemiology is very different at the community level than in the healthcare facilities, which is the basis for most of the literature, of the published and available literature. That we can identify TB and drug-resistant TB at an earlier stage of disease and potentially have an influence on mortality. That work is in progress. That we have a substantially lower proportion of HIV-TB co-infection at the community level in this rural sub-Saharan African setting, and that the overall rates of microbiologically confirmed TB are high in the community level. On the HIV side, certainly improving HIV diagnosis is feasible at a community level. People are accepting those kinds of services in this environment, that we need to provide comprehensive services, not just HIV testing, but the addition of CD4 count testing. But that certainly educating and providing information to patients about their status and even their CD4 count does not, and making them aware that they are eligible for treatment does not translate into increased ART initiation. So we need to identify the other obstacles and address those. Okay, quickly going through Isoniazid Preventive Therapy. What is Isoniazid Preventive Therapy? IPT, Isoniazid Preventive Therapy, is a strategy recommended for all HIV-positive patients, regardless of age, pregnancy status, CD4 count, and whether or not they've had a history of TB or not. What it is daily isoniazid. Again, remember that that's one of the anti-TB drugs, and one of the most potent ones. You take isoniazid daily for 6 months, and that will reduce your overall incidence of tuberculosis in the future. How long does that effect last? Currently, the best estimates are that if you take it for 6 months, it'll reduce your incidence of TB for another 18 months or so. Right now, it's being offered only to those patients, in South Africa, it's being offered only to those patients who are already in HIV care, i.e. those with a CD4 count less than 350 are already getting ART. And our project that we're starting up now is to implement IPT among those individuals identified through ICF at the community level, a population that's been neglected thus far. So we already, among those eligible for IPT in our current sample, those who are already getting ART, approximately 30% are receiving or have already completed 6 months of IPT. So we know that it's feasible. We have another 300 people who are not eligible for ART, but eligible for IPT, but are not currently able to access it. So this project is going to implement IPT among those eligible people and look at treatment outcomes and adherence. And then other future plans that we're starting is an evaluation of a rapid point-of-care CD4 count assay to evaluate this tool in a community setting, not in a healthcare setting, but out in the field, and compare it to the standard phlebotomized sample, and also look at its use in non-clinical hands. So most laboratory tests are done by clinicians, by nurses, and we're going to look at whether or not this test can be done by an HIV counselor who's not been clinically trained. Again, that would expand the reach of comprehensive HIV services at the community level, including being less reliant on highly skilled individuals, and allow us to decentralize HIV services. And this project is about to start. So in general, the World Health Organization's 3 I's is a comprehensive platform for combating tuberculosis. And at our site in South Africa, we're in the process of developing and implementing community-based interventions on all 3 fronts: infection control, intensive case finding, and isoniazid preventive therapy, to foster an effort to detect TB and HIV earlier, at an earlier stage of disease, and overall to improve patient outcomes and decrease transmission. Okay. Several people to acknowledge, certainly Jerry Friedland, who's here in the audience, Laurie Andrews from the AIDS program, our collaborators in South Africa, Anthony Mall and June Tombo, Tassos Kyriakides from the School of Public Health, Devesh Upadhyay, Sarasani, and Melissa Legizos who are students who've worked with us, Ralph Brooks from the AIDS program, my other mentors, Rick Altice, Rob Durrell, Dan Zelterman, and a whole host of funding agencies who've been instrumental to getting this work done.